Good morning. Thank you all for joining us so early today. My name is Cora Bruner. I use she, her pronouns, and I'm an adolescent medicine doctor and orthopedic doctor here at Seattle Children's Hospital and a member of the WCAAP, Washington Chapter AAP Equitable Care Committee. I am so excited to welcome you today to today's Equitable Care webinar. We're excited to bring our speakers today who will speak about a tribal community-based developmental clinic. Before we get started on their presentation, I'd like to share a bit about our committee, and then I will hand it over to Dr. Ezekiel Melquist, who will introduce today's speakers. The Washington Chapter AAP Equitable Care Committee is led by co-chairs Drs. Peter Asante, Kathleen Kieran, and Harbir Judge, and comprised of providers from diverse backgrounds and specialties throughout Washington State. Formed in 2020, the WCAAP Equity Work Group, now known as the Washington Chapter AAP Equitable Care Committee, collaborated to establish a toolkit with the goal of supporting clinics and healthcare providers and making healthcare more welcoming and responsive to families of color, delivering high-quality care to the diverse patients and families we serve in Washington State. Since 2020, the Washington Chapter AAP Equitable Care Committee has continued to produce monthly board-style questions to help providers challenge their knowledge of equitable care, as well as quarterly equitable care webinars. If you're interested in getting involved in the committee, it's a quick application, and the WCAAP staff has dropped a link in the chat for you. Next slide. Thank you. The original WCAAP Equitable Healthcare Toolkit has been provided to over 225 clinics throughout Washington, and the online PDF has been shared and referenced throughout the country. We recently finished revising the toolkit, and we're excited to announce that it will be available for download on the WCAAP website on Monday, October 21st. Woohoo! This updated toolkit includes case-based vignettes with topical self-reflective questions and discussion. In the meantime, our current version is still available. WCAAP staff will drop a link in the chat so that you can check it out. And it's won awards, you guys. This is a pretty cool toolkit, and the committee itself has also won awards through the AAP. Very proud of all of us. And with that, let's get into this webinar. I will hand it over to Zeke, who will introduce you to today's speakers.
Thank you so much for getting us started there, Cora. And thank everyone for being here. My name is Ezekiel Melquist. I'm a general pediatrician at Mason Health in Shelton, Washington. And I'm also a member of the WCAAP Equitable Care Committee. Very excited to introduce you to our speakers today, and they're going to share all about their tribal-based developmental clinic. First up, we have Dr. Komal Shah. Dr. Komal Shah is a general pediatrician who has worked with the Lummi Nation Health Center, LNHC, since 2018. LNHC is a comprehensive tribal medical home that includes family medicine, pediatrics, perinatal support, psychiatry, behavioral health, social work, public health, harm reduction, dental care, physical therapy, pharmacy, and ancillary services, including lab and x-ray. Dr. Shah oversees the Maternal Child Health Department, which provides pediatric primary care, child developmental and behavioral evaluations, perinatal care coordination, and the WIC Supplemental Nutrition Program. She also manages the Lummi Nation School-Based Health Center, which provides medical and dental services to children grades K through 12. Joining Dr. Shah today is Dr. Jennie McLaurin. Dr. Jennie McLaurin is a pediatrician with a fellowship year in developmental and behavioral health, as well as an MPH in maternal child health. She is certified in Washington as a Center of Excellence in Autism Diagnosis and enjoys seeing a diverse population of children with developmental differences. These include autism spectrum disorder, ADHD, sensory processing issues, genetic syndrome, cerebral palsy, school refusal, sleep disorders, and other challenges to typical development. At LNHC since 2023, she leads a new developmental clinic open to tribal members and also sees routine child health visits as needed. A community health worker and social worker assist these families in securing needed resources such as ABA therapy, DDA, SSI, disability parking passes, and school referrals. In her over 35 years in pediatrics, Jennie has chosen to work with Indigenous communities, migrant farm worker families, Native Hawaiians, immigrants, and other marginalized groups. She also serves as medical director of the Boyer Children's Clinic in Seattle, a leading provider of early intervention services for children ages birth to 3 years. And now I'm very happy to hand this over to our speakers. Thank you so much for joining us.
Great. Hi, everyone. Thanks for having us here to speak with you all today. And thank you for the introductions. This is Komal Shah speaking. We're going to just give you an overview of our experience implementing a tribal developmental and behavioral pediatrics program and what we found over the first year of our program. Next slide. Thank you. So for a little bit of context, we work for the Lummi Nation. The Lummi Nation is a federally recognized tribe and sovereign nation. The total population is about 6,500 with about 2,000 children. The health center is a division of the tribal government and within the Division of Health and Human Services. So that's along with other government divisions, including, typical things like planning, public works, natural resources, education. And so under the tribal government, there's also tribal education, including K-12 school and early learning and early support for infants and toddlers. Next slide. So the Lummi Nation Health Center utilizes funds from the Indian Health Service. Oh, a bit hard to hear and echo. Okay. We don't have headphones. We could remove ourselves from there. We could take this out. Give us a second here. We're gonna work with the audio. Can everyone hear us okay, or hear us a little bit better now? Okay, great. So the Lummi Nation Health Center is, we receive funds from the Indian Health Service, but it is an independent, tribally managed health center. As you heard in the introduction, it's truly a medical home. And the Lummi Nation is a small community, and so one of the benefits of working for the tribe is that we have direct access to community partners, such as the schools and child welfare and things like that. Next slide. As they said in the introduction, we have a number of services. It's primarily a family medicine clinic. But we do have a pediatrics department with 2 pediatric providers. Dr. McLaurin is our developmental pediatrician, perinatal support, social work, and we will be getting child psychiatry in the next few months here. Next slide. This is a picture of our the entrance to our pediatric department. It shows a little bit of the artwork that was incorporated throughout the clinic by Lummi Nation artists. And so now we'll shift to talking specifically about our pediatric developmental clinic. Next slide. So, in the last 5 years or so, the Lummi Nation Health Center, along with the Tribal Council and the community, saw an unmet need for early identification of developmental delays and developmental disorders and access to evaluation and services. 30% of children who attend the Lummi Nation school qualify for special education, which, as you may recognize, is a very high rate. However, in 2022, only 14 children in our health center were identified as having a diagnosis of autism. And so if you use the national prevalence of 1 in 36 children expected to have autism spectrum disorder, that would correlate to only a population of 500 children. Our patient population is 1,800 to 2,000, so this represents a clear underdiagnosis of autism spectrum disorder. We know that Native children are the least likely group to receive an autism diagnosis, but they're also the most likely to be in special education. And so this represents a health disparity in diagnosing these disorders. Next slide. Before we started the program, we identified several barriers to access. There was a 1 to 5 year wait for developmental evaluations. We did have a few options for developmental evaluations locally, but those services were a bit limited to our patient population. And so often they were having to travel 90 miles down to Seattle. And if they did access these outside providers for evaluations, the follow-up and resource support was not integrated with our community health center. If they did get the diagnosis and they got the prescription for ABA therapy, they faced an up to 1 year waiting list and still do for services. And transportation and other socioeconomic barriers also limited access. And then, of course, historic racism limits the trust that our families have in outside providers. And so ideally, we wanted to create an option for them to access that locally within their own community. Next slide. So a brief overview of our process here for the developmental clinic. Patients can get a referral to by their primary care doctor, behavioral health therapist, or from their school, from the Illumination School. Before the visit, once they've been referred, our community health worker provides a pre-visit kind of preparation for the visit by gathering medical records, behavioral health records, educational records, and helps with transportation and appointment reminders. And this community health worker is actually funded by the HCA Pediatric Community Health Worker grant, and is helpful for our patients because she is part of their community as a Lumming Tribal member. Appointments are 2 hours with 1 hour follow-ups. We do the evaluation in a play therapy room in the behavioral health part of the clinic. Dr. McLaurin utilizes standard evaluation tools, including the CARS-2. And then we provide referrals after the visit, and specifically a referral to our social work team, who will help families understand the diagnosis, navigate resources, and apply for services. Next slide.
Okay, thanks everybody. This is a picture of the salmon stream in our new clinic, which we moved into in July. It's a state-of-the-art, magnificent place, the nicest place I've ever worked in 36 years. So you're welcome to come and tour. Okay, next slide. So it's been just about 1 year. We started in October, and this is sort of a review of what we found. I've seen 82 individual children, some of them multiple times. I have seen children up to the age of 20. The primary reason they make a visit with me is concerns about autism, but it can be anything in the developmental behavioral health world. Of those 82 individuals, 59 got a diagnosis of autism spectrum disorder. 4 came in with a previous diagnosis from long ago that kind of needed updates. 55 were new. 14 had severe autism, so level 3. You can read this. 19 were under 5. And then a fatter portion were 5 to 10. One had been diagnosed as a littler kid, but the parent actually didn't understand that, which emphasizes the importance of this approach. Sadly, 17 were diagnosed not until age 11 to 20. The average diagnosis now at a year is 5.33 years. And we have good gender parity at this point, but we didn't initially, which I'll show you. Next slide. So the primary diagnosis from the center, they often have multiple diagnoses, as you know, but the primary diagnosis has been autism, followed by ADHD, then other diagnoses such as anxiety, and global delay, and a smaller portion is their primary diagnosis. Next slide. By severity, we see a nice kind of mostly level 2 at this point, some level 3 still as new diagnoses, and a nice amount of level 1 catching people in the milder stage. Next slide. The age of diagnosis, though, this is a real scatter graph, but what's kind of important to notice is there's sort of 2 clusters, one around age 11, one around age 3. Our goal is to move these bars down towards the younger age. We're not quite there, but we're getting there. Next slide. And of course, the AAP standard is before age 4. So here's a group of the autism comorbidities. They pretty much follow what you would expect. We have had several kids with a restrictive feeding disorder. Again, these are new diagnoses, so these are kids that haven't gotten therapy by and large, and it's not because Dr. Shah and colleagues didn't recognize needs. It's because there's been a real lack of access locally to getting things like feeding disorders without a diagnosis. And a few genetic syndromes, a few other things. Everybody asks us about in utero exposure to substances, and we're not going to give you a rate on that. It's something that we're looking at, but it is complexity to the picture. Next slide. Other diagnoses in children that didn't have autism who came in is sort of shown on the other one. We are getting sort of, I think it's sort of a fad for teenagers to hear that neurodiversity is common and that maybe they have ASD. I've gotten a few of those, but one kid who came in who's 17 who said she came because all her friends said she's neurodiverse and has autism. She did quite significantly. So they're not always wrong, but there is a little bit of that going on sometimes. And then other times parents see what we're doing and they think sort of anything that's developmental or unusual might be autism. We have a lot of sensory sensitivities and behavior issues that aren't autism. Next slide. So these are the supportive services that we mentioned at the beginning, and this slide is really just for you as your take-home resource. These are the things that we do. We also have a really nice resource packet for the parents that the community health worker goes over with them. And I'm now doing 1-month follow-ups just to make sure the parents all understand kind of a month later, how are you doing? What are your questions? Where are you going with this? Which again is something that doesn't happen either at Boyer or at Seattle Children's necessarily. And we found that it's a really helpful way to tie people back into the community and back into their regular continuity of care. We have been able to help people with sensory tools. We've helped people with Ben's Fund. We've helped people with a fund to get a special bed. And some other things that aren't our funds. Next slide. Sure, do this?
Yes, sure. So, we're hoping to collaborate a bit more with the community in further developing this program and resources. As you all know, the diagnosis is only the first step, and then it's how do we support these children. So we're hoping to develop tribe-based ABA services, including training tribal members to become ABA technicians. We're hoping to collaborate with our behavioral health department in that effort. We're hoping that some of those services could even be based in the tribal school, so either in early learning or in the K-12 school. We're hoping to provide education on early childhood development and managing some of these neurobehavioral disorders to staff at both the clinic and the schools. And we're hoping to develop more parent and community support groups. Dr. McLaurin is the medical director of the Boyer Children's Clinic, and so we're hoping to receive some coaching from their team as well. Next slide. So as I mentioned, we're planning, we will be having a child and adolescent psychiatrist join our team 2 days a week, hopefully in December or January. And so they will be a key team member for those children who have potentially co-occurring disorders, psychiatric disorders. We are, Dr. McLaurin is planning a staff training on sensory-friendly health center visits. So how to make the experience for these children less traumatic and more nurturing. For example, seeing children outside instead of in an enclosed exam room, dimming lights, things like that. And then we're hoping, we've started some outreach to the community as well to just give information on what autism is, what services we offer. So next slide.
So where are we? We're really happy with where we are at this point. Before this was started, we only had 14 kids diagnosed. And again, that represented a universe of 504 children with, if you were using common data on rates. But we had 73 children with any kind of developmental delay noted. And now we have 55 new diagnoses. And if you take out the 7 from other tribes, we're right at where we should be with a 1 in 36 for a population of 1,800 to 2,000. So it'll be interesting in the second year to see if it slows down, which is what we anticipate if we have sort of found that sweet spot of appropriate diagnosis. Many of the kids we do see multiple times. The parents have really liked this program a lot, and now some parents are self-referring. They still have to get the referral through Dr. Shaw, but they are coming for it. So the stigma bias part has really started to drift down. Our waiting time is less than 4 weeks. Our missed appointments are rare. I didn't actually do a rate because they were so rare. Then I had a missed appointment yesterday. Next slide. So just to put all this talk into trend data, what's exciting to me is when I looked at this back in March at 6 months, our average age at diagnosis was 6.6 years with the 2 peaks at 11 and at 3. And now we've gotten it down to an age of 5 years. Also exciting is that initially there was so much level 3 severity, over 50% at 6 months. Now we're down to 26%, also very exciting. Initially, mostly boys, and I knew we were missing the girls, and now we have a much more appropriate gender parity. Next slide. Oh, this is near you.
Sure, I'll take it.
Okay.
So we, continue to try to understand the kids that come in are complex. They don't just have autism. They don't just have developmental delays. We do have a high rate of substance exposure in utero and children who have experienced several adverse childhood experiences. And we know that all of these things overlap, and we know that they all contribute to the picture, to the child that we're seeing. And so we don't know how much all of these, each of these things contribute to the clinical picture, but it's something that we're working on. We're hoping to, as we said before, foster more community awareness of those critical 0 to 5, 0 to 3 early years, and the importance of early intervention and changing a child's trajectory. we are diagnosing children, but the time between the diagnosis and then access to services is still quite long. And we're hoping to collaborate more with schools, like we said before. Next slide. As we, as more children receive a diagnosis, we're thinking about what the future will look like for those children. And so, how will future adults navigate the world? Many of the level 3 children may not be able to live independently in their community. And so supports that the tribe may consider implementing include a tribal operated group home development and work skill opportunities. We also need to think about how these folks are received in the community and by institutions like law enforcement, and try to prevent unnecessary trauma and incarceration and manipulation. Next slide.
So, yeah, we have no end of things that we're thinking about, but we're thinking about it the way our green living wall will show you. We can grow, and we can be beautiful, and we can be tribally appropriate. These are our reinforced steel column. I think they're steel. Anyway, they're industrial strength columns that hold up our center, but they're wrapped in ancient cedar that the tribe can acquire from fallen trees and varnished and covered. So that's what we're trying to do. Strong supports covered by tribal care. We're going to run out of time, so instead of just, you can read, I know you all are good readers, so I'm going to highlight 3 children. One is an 11-year-old that came in early on, and he had been diagnosed with severe social anxiety, and he'd been seeing a psychiatrist in behavioral health. His parents were divorced. His father was furious with him for his inability to just cope with the world. Of course, that didn't help. And his mother was very understanding, but he decompensated whenever he was around his dad. And at school, the teachers loved him because he was sweet, again, 11, but didn't call on him because they knew it would bother him and let him just sit in the back with his hoodie on. When I said, actually, what you have is autism, it's not anxiety. I mean, you have anxiety, but it's really autism that no one is recognizing, including you. He jumped up, took off his hoodie, gave me a high five. And 3 months later, he'd gone up 2 levels in math. His mom told me he went trick-or-treating for the first time with friends, and that he was a changed kid. And that's just from being understood. Another one, not as happy story, but because he had a level 3 autism diagnosis instead of only behavioral oppositional diagnosis, when he fell apart and assaulted his mother and ended up needing to go to the ER, the ambulance driver saw the diagnosis of autism and treated him very kindly and very appropriately. And he actually got inpatient psych care that in part was based on having an autism diagnosis. And my third kid was a little nonverbal 3-year-old who is in the care of his grannies, and he came in a few months later. He was getting ABA, and he was talking, and he was like a changed little personality, and it was really fun to see. Next slide. So here's simple things you can start with. Disability parking pass, I am very liberal with. Just circle neurological as the chronic condition. Anybody who elopes or who is, one of my recent kids is 11 with level 2 autism. And he's so anxious if his mom has to park in a parking area that's far from the door, he won't get out of the car. So I gave her a disability parking pass, but just you're not going to get in trouble for giving people a disability parking pass if it's needed for either safety, not getting run over, or anxiety. Our community health worker helps with the DDA and SSI applications. You can prescribe ABA even if you're not a Center of Excellence person. There's a template that's a resource for you. Just use the sample form. The diagnosis has to be made, but use a sample form. We're giving people lots of information. We gave you some. You can look up sensory-friendly visits. There's some good YouTubes on it. There's a COE quick start guide from the Washington Department of Health. And I love STAT training. We're just getting started with it here, but it only takes 20 minutes. I love the Vanderbilt Kennedy Center for Autism. It's fabulous, and the link is there. Oh, and please, almost all the MCHATs I see are inaccurate. 18 months to 30 months, not 3-year-old, not 15-month-old. Oh, it's supposed to say 18, so that's incorrect on the slide. It's not 16. Really do it yourself because they're wrong almost always. Next slide. Okay, so I think you have a resource packet. I think we're here for questions with only 2 minutes over.
Thank you so much. That was fantastic. Wow. So many thought-provoking slides. And I have so many questions. There's a bunch of questions in the chat. So I'll get to those first. One is from Beth Ebel saying, love the 1-month follow-up to check on connection to services. In Seattle, that 1-month visit would be discouraging on the whole because challenges getting into service in any timely way. The next one from Beth is huge.
Wait, that 1-month visit would be discouraging on the whole?
I think.
Oh, it's actually it's not, because I don't expect that they're in services yet, but a lot of times there's a lot of energy right at the diagnosis time, and then everybody sort of gets overwhelmed and peters out. So I like having them come back and just find out how they're doing. And then that's not the only time I'll see them, but it lets them go back to the community health worker if they haven't. Some of them haven't. It's, did you get your disability parking pass? Oh, I lost the prescription. So it helps like continuity, and then it helps us keep a tagline on sort of who needs more assistance and who doesn't.
I just think, are you just automatically scheduling 2 appointments though? Because I think I get what Beth is talking about, because some of us book appointments and then we're booked out again for 6 months. So do you just automatically book 2 at once, which is the intake or whatever first? And then
well, the follow-up is shorter, and we right now we do have an open schedule. So I guess it depends on how booked up you are.
Okay.
But I do have protected schedules, and I don't always do a 1-month follow-up if they're from another tribe, okay, or otherwise. So and it's not at our center. It's not hard. I get it at other places.
Okay.
Somebody asked about foster care, and tribal foster care, Dr. Shaw can explain, is a little different, but yes, we actually have kids coming into us who are in foster care. A lot of it's kinship care, but
yeah, sorry, I'm just taking a look at the question. Send children, here for office evaluations, or if, okay. Gotcha. Oh, okay. And are you able to follow the children from the community who are placed in foster care? Okay, gotcha. Yes. So, yes, so our clinic is able to see any child who is enrolled, who is an American Indian, Alaska Native, enrolled in a federally recognized tribe. And so you don't have to receive primary care here. If you are in a foster placement, it's your tribal enrollment that matters. If they do get placed into foster care, we are able to follow those children. We try to we utilize our social worker and our connection with Lumbee Child Welfare to see where those children were placed and try to bring them back to the clinic. But that is a struggle, not even just in this program, but even in primary care, to get those children back to their community for care.
And another question was about Autumn. You were asking about if you could send children that are members of a different tribe, and the answer is yes. They have to be a tribal enrolled member of some tribe at this point, and right now we do have openings. for enough that like I'm not crammed full. And I expect that's going to continue to be opened up as we expect our levels to go down a bit, our need. So you would need to contact us and we can explain what our process is. Their PCP ideally would be referring them, but to our community health worker intake or to Dr. Shaw. But yes, we can take children from any tribe. Examples of how I've adapted diagnostic tools. Yes, so one example is, okay, so I've been doing this a very long time, 36 years. And I am reassured that when I go to developmental behavioral meetings with the AAP, that the other developmental behavioral pediatricians who are the leaders and who are board certified in it, which I'm not, because I went a different route, aren't typically using the ADOS and they're typically doing it as a diagnostic, holistic, comprehensive exam. I use the CARS because it's quick and it's a good format for me. Typically, I'll get a higher score on a CARS than I do on a child IC, which to me is reassuring because it'll see more symptoms. It'll give them a more severe rating than I might, so I don't feel that I'm overdiagnosing. But one of the things is eye contact. I had a tribal grandmother say, in Native culture, our eye contact is low, and I agree, it is. And if you watch dances and everything else, it's very low. And so her grandson said, but grandma, mine is because I'm not comfortable with it. So trying to get to the nuance of the eye contact can be hard. But so what I ask is it lower than your friends? Is it lower than peers? Is it lower than what you expect in your community? So eye contact is one of those symptoms that's definitely cultural. Conversation can be also similar. So we talk about what do the other kids talk about and what are you talking about with them? But other than that, a lot of sensory sensitivities are sensory sensitivities and they're not really cultural. And the same with the restricted behaviors. Other questions?
It does look like there's a question about how we're funded. And that other folks in private practice have had a hard time sustaining the program with just insurance reimbursement. And so we are lucky in the sense that working for a tribal health center with a largely Medicaid insured patient population, we kind of operate like a federally qualified health center in that we receive an encounter rate. And so Dr. McLaurin may see 4 evaluations in a day, but all of our other providers, right? All of our other providers are seeing a full schedule. And so, but all of us are receiving an encounter rate for the children that we see for the majority of them. And so, you know, that is we're lucky in that way that we can fund this service. I do understand that it would be difficult for a private practice.
Yeah, it's difficult for Boyer. So Boyer is spectacular in terms of its Medicaid take and everything else, and it works with the domestic violence shelter. So Boyer isn't just rich people in Seattle, but they have a big charitable arm and they have fundraising and stuff. So I think, yeah, you need partners. But I don't know, you know, what grants are available out there or whatever, but certainly having the help for our community health worker is priceless. So Dr. Shaw mentioned how, you know, she came to be thanks to AAP. So, yeah, it takes some cobbling together. And we have asked Lummi Nation School about doing ABA there, and so in the future, we actually we thought we were going to have an ABA partnership this year, and it hasn't gone forward yet. So we're still working on it, but we have gotten kids into ABA the traditional way. But a lot of tribal people don't want people in their house. So that can be a problem with some of these therapies where the therapists are meant to come to their houses.
Mm-hmm. And I see that Christina mentioned that there's a, you know, the referrals to speech and OT and ABA, and then the long wait can be really discouraging. And so there's free online ADEPT videos, which I'm not familiar with, but maybe.
And in our resource packet there, I really love the social it's social talk videos. They're at the bottom, they're in your resource packet under the videos and stuff, and they train social skills. They're really, really good, and they're like 5 minutes long, and they're little things on sharing and stuff, and they're for school age. So there are a lot of online things. There's an online game that a dad who had a son with autism developed. It's kind of like Minecraft, but it's for autism. So there are online things for sure, and our families have as much online as anybody else. So that's not a deficit here. How do we maintain our own wellness, Dr. Shaw? Well, we love doing 7 a.m. webinars. That's really good. That is so good for our wellness.
I'm impressed by the number of people here.
Yeah, me too.
But I will say that working at Lummi Nation Health Center is a really different experience than working at other clinics that I've been at. It really is a community and a community-based clinic. We start our morning every day with, we call it morning report. So it's not like residency, you know, morning report with a case or anything like that, but all of our staff, including providers, nurses, MAs, social work, physical therapy, front desk, people, we gather and we share announcements, and it really occasionally, if you know, there's a big community event, like something good, like a cultural event happening, that information is shared. If there's a loss in the community, a death, that is also shared. And so it's just a really great way to all start together, and a good way to start the day. And staying involved with community events and seeing our patients outside of the clinic is really fulfilling.
Yeah, and like I said, I've done this a long time with lots of different groups, and this facility is spectacular, which is by itself is a wellness thing. Having the time that I need. So at my age, I work for Boyer and for Lummi because both of them give me the time that I need. I can do a really good job, and I'm not going to work in a place that won't let me do a good job. So that's something.
And we're not open on the weekends.
We're not open on the weekends. I also am now seeing just sick kid visits and a few, visits if they need me to. On Wednesdays, which incorporates me better into the community as a trusted pediatrician. Oh yeah, I saw her when my kid had an earache, and that's good. But yeah, I do a lot with my own wellness, hiking and tennis and other things. But I can talk a long time, but I'll give you my 4 tips for taking a job. Work in a place that's committed to excellence. If you're committed to excellence, or it won't work out. Work in a place that's joyful if that feeds your soul at work, or your soul won't get fed. Work in a place that pays you according to what your family has decided that you need, that's fair and just, or you'll resent it, or you'll have to quit even if it's joyful and excellent. And work in a place where you're respected for who you are, and so is everybody else who works there for their level of work. That's, for me, those are my 4 pillars. Take them or leave them.
Did we miss any other questions in the chat? Does anyone else have any other questions?
There's a couple of people that are questioning what ABA
Oh, applied
is.
behavioral analysis. Yes, ABA, and it's the little it's not the only, but it's the primary therapy that has actually been studied as effective in autism therapy that's directed towards the high need behavioral changes. So it's behaviorally focused, and it is a one-on-one kind of therapy, very intense. Intense not pleasurable, but intense as one-on-one for 2 hours at a time, several days a week, typically. And it got a very bad rap because it was very rigid, militaristic, and punitive in its beginnings. A good ABA therapy program now is child-led and child-centered, not therapist-led. And it's always teamwork with a parent. So I have to debunk a lot of bad ABA stuff on the internet because there's a lot of harsh stories out there, and parents are like, my kid's not getting ABA. You're trying to mold them into a robot and turn them typical. And it's like, nope, your kid is your kid. Autism is not a disease. It's another operating system. It's like having a Mac and a PC. But if you want them to be able to play together and understand each other, and you're scared of your kid getting hit by a car in a parking lot, ABA can really help with going over and over and over again, green light, red light, stop, don't move. If your kid is super picky with food and can't stand anything new, ABA therapists can sit with them at dinner with your family and help them not freak out over dinner and just get to where they can try stuff a little tiny bit at a time. So it's tiny incremental behavioral changes that are repetitive, done until the child can do it.
Thank you. I think there has been a lot of issues around it in the past, which do need to be debunked, because I remember when it started, and now I'm fully aware of how it's morphed over the years to a much more child-led intervention.
Yeah, and a lot of it is in autism in general, but I think specifically here where there has been so much labeling, dumb and yens was a phrase. Lummy dummies, that was a phrase in the public schools here. Yeah, at Arndale where I live. So making sure that when parents ask about labels, I always start by saying it has nothing to do with personality, nothing to do with intelligence. You can be anybody and be autistic. It's just another way of receiving information in the world. But you want to be able to flourish and be yourself and be fully a part of the tribe. So how can we help that happen?
Mm-hmm.
Lots of praise in the chat, you guys. Lots of praise in the chat. One question I have is, do you have members of your staff who are neurodivergent?
Yeah, in fact, our community health worker, I bet she would describe herself as neurodivergent. I do.
Mm-hmm.
Yeah.
Yeah, you said, I think when you first joined the clinic and we did a little presentation on this, there was a staff member who came up to you, right? And said, thank you.
Yeah.
Because
I
think I have autism or something like that, and it's nice to be recognized.
Yeah, I'd forgotten about that.
Mm-hmm. I don't know if there's ABA therapy for adults.
Yes, there actually is, but it's pretty rare. It's usually in the level 3 people that are in like group homes and stuff. But so for adults, if you're going to think about what's a companion, dialectical behavioral therapy is a typical step down from ABA, right? You're working on changing behavior and modeling it, and maybe we'll do it this way, right? You do it with toddlers all the time naturally, but
yeah.
I have a question. Oh, thank you so much for joining us and the presentation. It was amazing. I'm kind of wondering if there are any times where you've had to adapt your explanation of autism, or what it means, because it kind of gets at the core of our identity and so much with our cultural identity and individual identity and family identity. And I know with some of the families I work with, I have to shift how I'm explaining kind of what the underlying etiology is, if for lack of a better term. But are there times or examples where you had to do that, in a particularly with this tribal community understanding? Does that make sense?
Yeah, I would say I've had to, in the beginning, I had to do it a fair amount because of the concern that this white lady is going to label me with something and then it's going to follow me as a stigma. But where I do it all the time is at Boyer, because we have a very international group of children coming in. And I always ask the parents before I give a diagnosis, tell me what autism means to you. Because I want to hear what they think it is, right? So I've had parents say it means that the child's going to be aggressive and antisocial. I've had people say they're never going to learn. I've had people say, in my country, we don't have autism. I've had a lot of that. So I do try to respond individually to wherever they are on that road. And I will say, it hasn't happened at Lummi yet. It has happened there's one kid at Lummi school where it should have happened. But at Boyer, it's happened several times where the child actually meets the criteria, the parent doesn't want the diagnosis. And I can just see they're about to blow up and explode, and it's okay. Mm-hmm. So it's not like giving them a diagnosis of hypertension or diabetes, insulin-dependent diabetes, where you get CPS involved if the parent refused the diagnosis. We do get CPS involved for level 3 nonverbal kids who are getting 0 and not even going to school, because that's not okay. But at Boyer, I have said, I'm going to write up my report saying that this is where, here's the DSM-5 criteria, and I go over it. And this is where your child is on that, but we're withholding an autism diagnosis at your preference right now. I would suggest that you maybe look at this again in a year. And I've gotten people to be more receptive to continue therapy, to continue doing speech. And again, this is 0 to 3, so we have a little time, but to keep participating in therapy rather than shut out and go away. So that's, I think, where the art comes in versus the science. I can make people fit a DSM-5 criteria. I don't know if it's always helpful.
And this is not specific to autism, but I recall a patient of mine that was having an evaluation for ADHD and met the criteria. And his mother was there and his grandfather was there, and his grandfather said, well, like in our culture, we don't have this. We didn't used to diagnose people with ADHD. They were just part of the community. They were the people who were going to be the hunters and gatherers, and they didn't need medicine. And that makes a lot of sense. And I recognize that, yes, that's, your child or your grandchild is living in a world that, and in a school system that doesn't match your cultural roots. And so they're having to adapt to this. And we're just trying to help them, thrive in the community that they live in, but also recognizing that, yes, maybe this isn't the way that culturally you would view.
I think ADHD actually is more difficult because people are also very afraid of stimulants because of drug addiction. And so they're trying to raise children without drugs. And so that's a lot. I think that's a lot more difficult. And I think, again, just emphasizing there is nothing I'm going to do that's going to change your child's personality. And if you feel like it is changing, then you need to tell me right away, because that's not the goal. We might need some behaviors to be a little more social so that they can be happier. And you can help them learn better, but we're not trying to change who they are. Yeah. And yeah, everybody asks me, like, what's the cause? What's the cause? I'm putting it right out here. The future, I'll probably be dead, but microplastics is what I think. In terms of the rate rising everywhere, the highest rate being in Qatar.
Cora, do you mean engaging law enforcement in education,
Yeah,
or?
I was trying to type and managed 6 things.
Oh, not yet, but that's a great idea. We want to do community presentations. And so, yes, because we do know that people with autism are more likely to be accosted and inappropriately hurt by law enforcement. I still think that boy who loved the animals at the pet shelter and played violin to them and was African American and got shot on his way home. I think he was autistic. I mean, he sounds like it. He was so sweet, and not knowing how to respond and not being recognized as neurodiverse is really hard. And certainly there have been autistic people gunned down for not responding to police appropriately.
So many wonderful praises for you in the chat. I'm like, I could talk to you two for the rest of the day. But yeah, it is definitely so many things. I have so many thoughts. I feel, because I work in the juvenile justice system too, and I do know that we do have youth that are incarcerated that really have not been diagnosed as neurodivergent, and
also with ADHD.
Yeah.
So that's one of my claims for stimulants is I tell them you're more likely to be jailed if you have untreated ADHD. Sorry.
That's okay. So Jim Polo has a great comment about autism spectrum disorder, spans a significant spectrum, multiple causes. Crystal says, everybody's saying thank you. You're amazing, everybody.
Cora, can I?
Yep.
I just want to point out that Kate Orville put her information in the chat there. And if anyone is interested in getting involved with autism diagnoses, she's incredibly helpful. So, and can really grease the wheels for making that happen for you.
Yes, she was very helpful for our team as we got started.
Yeah, and we're happy for people to come and see what we're doing. And if anybody wants to shadow, we could possibly work that out. Don't flood us with that right this second. But we could probably work it out. Thanks, everybody.
Thanks, everybody. All right.
Thank
Well,
you.
I'm going to wrap this up and give you a minute to go to your next event. Thank you, and enjoy this peaceful, calm, and thought-provoking presentation. I just feel so hopeful hearing these two incredible providers speak, and also seeing all of you listen to them. It just gives me so much to think about. And in terms of equity, everybody deserves our care, and everybody deserves the respect. So thanks, everybody. Have a great day.
Indeed. We'll see you in December. Thank you.
Take care.